Good afternoon to all participants on behalf of dentalvriksha.com. I sincerely thank and welcome my dear friend and a wonderful periodontist, Dr. M.S. Muthu. Thank you, Dr. Muthu, for your time and accepting our request to present in a dental webinar Zoom meeting. A small introduction about Dr. Muthu. Almost he is popular and no, there is no introduction needed, but still it is a formality. So Dr. Muthu finished his BDS in Government Dental College, Chennai, and MDS at Nair Hospital, Mumbai. He did his PhD in Meenakshi Academy of Higher Education and Research, Chennai. He did his MFD as RCPS in Glasgow. With more than 20 years of experience in academy and research, he is currently working now as additional dean in research head Center for Early Childhood Caries Research, Sri Ramachandra Institute. He is Outstanding Dentist Awardee in 2016 by FAMDent. He is winner of Dr. Lakshman Gold Medal in 2016, 2017, 19, 20, 23, and 25. And he has given publications for more than 130, 35 systematic reviews and 5 Cochrane reviews, and co-founder of startup Ignobilis, Consultancy Terrain LLP, M Health, Research Consultancy, and Capacity Building. The list still goes on, but it will take more than 10 minutes. So I don't want to waste your time. Over to you, Dr. Muthu. We are eagerly waiting for your presentation. Thank you. Over to you. The stage is yours now.
Thank you, Dr. Mani. Am I audible?
Yes, Dr. Muthu. The screen is visible and you are audible also. Please proceed.
Okay. Thank you very much. And thank you very much for the introduction. Thank you for the opportunity to share my experiences here. And for everyone, Dr. Manikvasam was our very pleasant senior we had in Madras Dental College. I did my BDS between 90 to 95. When I joined my dental BDS program, Dr. Manikvasam was in the final year, if I'm not wrong. And we all used to like him as a senior for his very pleasant and very humble interactions. And after a very, very long time, we are connecting back. And I know we've been talking about this for quite some time, this session. And I'm glad that it happened now. And so at the outset, my gratitude to Dr. Manikavasagam and the dentalvriksha.com team, if others are involved in this as well. And also I welcome all the participants who I think somebody...
Other participants, kindly mute yourselves so that we can hear the speaker, please. Thank you.
Gel போட்டுட்டு சாப்பிடலாம். Gel போட்டு டென்சர் போட்டு சாப்பிடலாம். அப்புறமா ரிமூவ் பண்ணிடுங்க. That YT. ZT.
Is there any way we can mute that part? Yeah. Okay. Thank you. Let me go back to the screen. If I'm already sharing, then let me go back to my slides. That's all. Just let me click this one. Just came out of the screen. Yeah. Okay. It's visible, right? The screen is on.
Yes, Dr. Muthu. It's visible.
Yeah. So the topic for today is early childhood caries, a different disease. And I have spent enormous amount of time in this area as a pediatric dentist. And to disclose, there are no competing financial interest in this presentation. And this is my everyday life, probably for more than 2 decades now. I joined my pediatric dentistry in 97. And since then, I'm treating only children. And we have set up this Center for Early Childhood Caries in the research in the campus in Ramachandra University in 2018. And I have committed myself to do research in this area since 2010. So we have done some fantastic contributions in terms of research, in terms of publications, in terms of grants, in terms of clinically relevant outputs. In fact, I would rather say that I understood this disease better today comparing to 10, 15 years back, because many of my perceptions about this disease was incorrect, which I know now. But I was already practicing pediatric dentistry for many years. So I'm going to share some of these outputs which are relevant for any dentist who is handling children. So this is my current role in the university, as well as a head of the Center for Early Childhood Caries Research. We call it as SICRI. We do an annual conference every year in the month of August, 29th and 30. I welcome all of you. You can look for us in the social media, and it's a conference is generally a free of cost conference. It's a online conference. We constantly update what's going on from our center, as well as we bring in people from rest of the world as well. So this is where the center is. I'm based in Chennai. That's a city south of India. I know some of you might be from outside. And if you visit India and if you're coming to Chennai, please drop in. We'll be happy to host you. You can come and visit our center and the team involved in SICRI. So the topic is, as I told earlier, early childhood caries. We're going to talk in breadth and length of this problem and the broad outline. And all of these things largely coming from the outputs from the center and from our research in the last 10, 15 years. And many of these things might be little new for you. If you're a general dentist and you will be seeing patients, you'll be treating children, because I truly understand that at least in India, probably 5% of the children are treated by pediatric dentists. Maybe the rest of the 95% of children are probably treated by general dentists. So it's good to know this disease very well, how it begins and where the problem is and where the misconceptions are, the role of the feeding practices and the role of enamel defects in this disease, and the concept of sustained anticipatory guidance that's completely indigenous, the math charts, and the relevance of Oakes studies and the proximal caries in children, which I'm sure that all of you will be struggling to restore these class 2 cavities in primary teeth, and some treatment options and rehabilitation options. So there'll be a lot of scientific content coming into this presentation in terms of papers and research as well. At the same time, I try to keep it very relevant to a dentist who is practicing on a daily basis in your own practices, wherever you are. So let's move forward. If you look at the public health burden of this disease, you'll be very, very surprised to know the data of this globally. It's important to know this kind of theoretically, at least, even though many pediatricians or many general dentists tend to consider this as a milk teeth and it will fall off, new teeth will come. These advices are given generally on a regular basis. And one of my intent of this presentation is, at the end of this presentation, I would like you to have a different perspective of this disease in terms of occurrence, in terms of management, in terms of a child behind this disease, and all those things. I'm sure that you will have a different perspective after this presentation. So if you look at this prevalence of this disease, you go and talk to any epidemiologist, and if you say this, at age 1, the prevalence of this disease is 10%. You will very rarely come across another disease where you have prevalence of 10% at age 1. Okay, probably bronchial asthma could be there, but otherwise you may not find any other disease known to mankind at this kind of a prevalence. So that means one child out of every 10 children, 10 infants, are having early childhood caries. If you go one more year later, it becomes 23%. You go one more year later, it becomes 33%. And you go a little further, it becomes 45 to 55%. So by 5-6 years of age, technically every alternate child has this problem. We'll also look at this definition as we go along, but I want you to keep this prevalence at the back of your mind. Every single day I go to my practice, I don't remember, was there any day where I have not seen a child with early childhood caries in my clinic, and I came back from the clinic without seeing one. So it's quite many years, and the burden on this society, in the family, in the country, across the globe is unimaginable. So it's an economic burden to handle this. It's a social burden because the child has a chronic disease, most often left untreated. And there is a family connected to the child, and there's a society connected to this family. And there's a large amount of rehabilitation burden. You go to any of the developed countries, you'll be amazed, you'll be surprised that there are waiting lists for 3 months, 4 months, 5 months to be operated under general anesthesia in the theater. 3 months. And when I visited Australia almost 5-6 years back, it used to be 9 to 11 months waiting list to treat a child under anesthesia in the hospital. Recently, when I went, probably it's come to around 3 to 4 months now. So it's huge burden in terms of rehabilitating this disease. So the intent of this presentation is to look as a healthcare provider, as a dental service provider. I want you to think from that perspective. There is a great possibility to prevent this disease at age 1. And thereafter, the scope for prevention becomes less and less, and you have more burden to handle. So we'll come back to this later. And right now, if you go back to the age 1 first dental visit policy, globally, the first dental visit policy came in 1990 in the US, that they recommended the first dental visit of a child should begin by 1 year of age or as soon as the first tooth comes into the mouth. When I was studying BDS, that is between 90 to 95, I was not aware of this policy. And most of the textbooks used to say the recommended age for first dental visit was 3 years. And this policy came in 1990. I had an interaction in 2019 with one of the highly positioned pediatric dentist in the US. I asked him this question in one of the International Association of Pediatric Dentistry meeting, that is 2019, almost 30 years later. What is the percentage of children coming to age 1 dental visit in the United States? He told me that, don't quote me on this, I don't have an exact number, but it could be around 30%. 30 years later, the policy came into the US, 30% of children coming for age 1 first dental visit. That means that's the only point where you can capture this at the 10% prevalence. Because you'll wait for a year, it's more than double. So let's keep this at the back of our mind. Let's go to this very important finding: enamel hypoplasia, enamel defects, and early childhood caries. This is kind of published quite an extent in pediatric dentist literature, but it was published along with numerous other risk factors associated with this disease. So recently, 2018-19, that's around 6-7 years back, we came to know that this is an important finding, probably the number 1 risk factor for early childhood caries among the 123 or 120 plus risk factors associated with this disease. So we wanted to know what the pediatric dentists think about this enamel defects, or the role of enamel defects in occurrence of early childhood caries. So we put some of these definitions and also some pictures. So this is a 14-month-old infant. You look at the teeth. Of course, as a dentist, you can see some changes on the enamel surface. Okay. It's a 14-month-old infant. I'll show you another picture. This is another 14-month-old infant. Okay. So okay. So if you look at these images, and the question is, how this happened on this enamel surface? Does plaque have a role in this, or is it a developmental defect? So we thought, let us see what the pediatric dentists think. So I sent out these two images with few questions, very simple questions. And now we have collaboration across the globe. In fact, all the continents, we have some partnership, some collaboration, some research work going on at this point of time. So we could reach to few of the pediatric dentists in different parts of the world. And we asked 4 key questions. Okay, these are the number. This is the representative. All of them were pediatric dentists. Majority of them were in practice as well as teaching, and some of them were in research and teaching, not in practice. Very few of them. Most of them are practicing pediatric dentists. And let's go to the question and the answer. I asked this question: the white patches on the enamel surface can be diagnosed as. So I gave these 4 or 5 choices and asked them to choose in the Google form. And I also allowed them to choose more than one option. Okay. So look at the terminology and look at the answers. The answers on the top of this slide, the first, table kind of thing, they have given only one answer. 3 pediatric dentists have said what you see on the picture is enamel hypoplasia. 7 of them have told demineralized enamel surface. 5 of them said it's non-cavitated lesion. 5 of them said enamel opacities. 7 of them said it's white spot lesion. And the remaining pediatric dentists chose combination. They picked up more than one terminology. Okay. So let's go to the next image, the same question. And this was the response for the other image, what you see on the left. So it's obvious that pediatric dentists themselves perceive this in different ways. All these terminologies, I'm sure as a dentist, all of us are familiar with. And cavitated, non-cavitated lesions are the terminologies used in the ICDAS, International Caries Detection and Assessment System, which is the most robust, advanced way of documenting caries, as well as in the clinical as well as the research setup. So they use these non-cavitated lesion, cavitated lesion terminology. And many of your practitioners, I'm sure that you might have also heard these terms. And none of these terms will be something which is new. You would have definitely heard this quite many times. So the other question what we asked was the changes, the white patches on the enamel surface, or both the images we gave this as 2 different questions, are a result of plaque-induced demineralization occurring after the teeth erupts into the oral cavity. The above statement is true or false. You look at 55 of them said it is all plaque-induced demineralization, and the tooth comes normally into the mouth, and then later on, these changes happen. And the other question is the changes on the enamel surface is a developmental defect occurring during tooth development, and the tooth erupts into the oral cavity with the changes on the enamel. The above statement is true or false. So you look at the perception. Okay, I'm talking about the most qualified people in pediatric dentistry. The intent of this is to only bring this knowledge to the platform to more people, as many people as possible, not to put anybody down or up. Even I also used to think in a different way for almost 15, 17 years as a pediatric dentist, but now we see this in a different way. Having said that, we have not given these terminologies in that question, developmental defects of enamel or enamel defects or hypomineralized enamel. Let's go into the definition of early childhood caries. In the question, in the survey, we also gave a space. If you want to write something else, you can write. That means there is a blank lines. You can write other than these terms, what we have given as choices. You can pick up something else as well. You can write something else as well. So if you look at the definition, I know many of you are practitioners, you may not really look at, our definition may not be a real-time day-to-day affair, but it's important to understand this definition because it's clearly says one or more decade that could be non-cavitated or cavitated lesion, only one or more, even if it's one non-cavitated lesion or more non-cavitated lesion or one cavitated lesion or more cavitated lesion, you call it as early childhood caries under 6 years of age. This was taught to us as rampant caries. When we studied, even during quite a bit of my master's time, it all went towards rampant caries or nursing bottle caries and all these things. This terminology came in 1998. This is a revised definition, which came along with the Bangkok Declaration, which happened in 2018. So now basically any child who comes less than 6 years of age, even if the child has only one cavity in the mouth or one non-cavitated lesion like a white patch is there, you are supposed to diagnose this as early childhood caries. But that doesn't happen in practice. Okay, that is not reality. So many of them, if you closely look at this picture and reflect on it, ideally this picture should have been diagnosed as early childhood caries because there are more than one non-cavitated lesion, which is very obvious. At least 3 or 4 teeth are involved. And whatever term we can say that we can definitely say is a non-cavitated lesion, okay? Or probably the right central incisor on the upper, the image on the upper jaw in the top of the slide have some enamel breakdown. Probably you can also categorize that as a cavitated lesion. But majority of them, except handful of people, they've not written this as early childhood caries. It was not diagnosed because it first, in epidemiology or in research and even in clinical practice, first, how do you define a disease? When do you diagnose this as disease is very important. When we see the early signs or the initial changes of the disease, if it's not perceived as disease, we tend to leave this as it is. And eventually it might develop into a full-blown disease. So having said that, let me come to the point why this is important, right? This is a systematic review. This is one of the biggest outputs came from the center. And this is one of our papers, one of the most cited papers in early childhood caries research. I know if, I can send all of these papers to you later on. This is the paper which told us that enamel defects are the #1 risk factor. In health sciences, you don't see odds of 14. In any, probably very, very unlikely, you see an odds ratio of 14. So this was a big surprise and it changed all our practice. In my practice, we changed after this paper. The whole approach towards early childhood caries management dramatically changed. I'll show you some evidence of these changes, which is in practice, which you can do as well. So this was a big revelation. 1 year later, another paper came in. It's all in the very big journals, Q1 top-rated journals in pediatric dentistry, in caries research, etc. So this paper reiterated the same thing. They brought all the systematic reviews together, and we all know that systematic reviews stand at the top of the evidence-based pyramid. It provides the highest level of evidence. It said the same thing, what we said. Enamel defects are the #1 risk factor. So now let's look at the definition of this, how we were taught in dentistry. Developmental defects of enamel hyperplasia, enamel hypermineralization, white spot lesions. I put the definition here and the corresponding references. I just highlighted certain portion of the definition because we all have heard this term. We all have our own perception. We all treat children. We all treat patients every day. So because of these terminologies, various ways it's been taught, it's being represented, it's documented, it's presented in scientific literature. But if you put all these together, if you see the definition here, let me go to the next slide. I put the definitions here. And now you look at the definition against this picture. Any aberration in the quality and quantity of dental enamel, called as DDE. Obviously, you can probably, both the picture will fall into that. You come to the next picture. Quantitative defect, presenting as a deficiency of enamel. Yes, there is a quantitative defect, at least in the one of the incisor. You can say that there is a slight breakdown. Probably there's a loss of enamel there. And may not be other teeth if you put it a classical definition of enamel hyperplasia. You take enamel hypomineralization, alterations in translucency or opacity, all the teeth will fit into this. White spot lesions is one which is widely used in permanent teeth and most often in orthodontic literature after around the brackets and things like that. We don't use normally the white spot lesions as a terminology in the primary teeth. This is what I'm telling in the literature. So these pictures fit into one or more than the above definitions. So keeping this as a background, let's look into this. It's again a very interesting paper. Hypoplasia associated early childhood caries. It's called HACCC. I will connect all these things for your practice, how you can use this in your practice later on. This is an interesting paper, came in 2012. Okay. And they characteristically said that all these teeth, the white patches are developmental defects of enamel. And if you look at the table on the left side here, most of them related to factors during pregnancy. We all know that all these teeth form during pregnancy. Now, during the formation, there is some disturbance. We do not know what exactly even today. And this disturbance is not continuous. It is intermittent. So the formation of enamel goes through certain disturbance, and they all come with erupted with enamel defects. So that's why if you see most of the parents, I'm sure every dentist who's here would have heard this from the parent, that they have told you that the teeth came like this only, doctor. The teeth came like this. We have heard many years in our exclusive pediatric practice, but we always said, no, how the teeth can come like this. So now we know the teeth has come with these defects. It is not plaque induced, and probably it can overwhelm or it can be additional factors, but the teeth comes with these defects. So if you look at this paper, clinical examinations of very young children, as the teeth emerge along with the pattern, will facilitate a differential diagnosis. As perhaps those who develop nursing bottle caries have enamel hyperplasia as an antecedent. Okay, you'll be very surprised. And I presented these things wherever I had a chance to present to any general dentist or pediatrician, because it's very important to understand this in this way. And now let's look at some of the pictures. Okay, this is for all of you. I'm sure you would have seen these pictures in your practice. And I want you to pay close attention to the teeth, the surface, the way enamel has broken down, the margins of the cavitated part, wherever the enamel is lost, and look at the borders. Okay, keep looking at. And if you are a very committed, focused clinician who treats patients every day, this question would have happened to you as well. This question was there in my mind for many years. Why only some part of the enamel or some part of the teeth gets affected in the same oral cavity, same oral flora, same microbial interaction, same dietary practices, same food and everything same. Why only some surfaces are getting affected? You look at the borders. Okay, there, if you look at this image, what is on the screen, if you focus on the central incisor, the two central incisors have come into the mouth early, and the incisal edge came into the mouth early, but that has not broken down, but only the cervical parts have broken down. You look at the canine, there are certain parts of it's broken, and all the broken down part has a white border. So it's very simple, logical to think that the certain surfaces of enamel have come with that white patches which I showed earlier. And on top of that, probably plaque accumulated, food accumulated, improper oral hygiene practices, all the theory of Miller's and all what has been taught to us for cause for dental caries, you can put in there. Probably enamel is broken down. But the fundamental problem, you look at every single patient with a nursing bottle caries, you'll be surprised to see this pattern on every child. Okay. I want you to go back to your practice tomorrow, maybe today, later in the evening, tomorrow, day after. When you see a child 3, 4 years old, when you examine the mouth, ask this question: why only some part of the teeth has been affected? Why the other surfaces, even though it has come into the mouth ahead of time? In fact, it has been exposed to the saliva and the microbial interaction for more duration than the certain parts. So it's very important to understand this in this way, because even now, the pediatric dental community is fragmented in terms whether probably some of them may not agree that the tooth is coming with the defects. But I'm telling you, with all these 12, 15 years of research and experience and numerous publication, we had multiple cohorts of infants in various studies. We have taken children before the teeth comes into the mouth. We have seen them for 2.5 years until the child becomes 30 months, 36 months. Not once, from 2015 onwards, multiple times. So I've seen these teeth coming normally with some very small enamel patches or lines or diffuse or demarcated opacities. In no time, it breaks down, if you leave it untreated. So there is a very small window for us to act. And every patient, one after the other, you go back, you will see this pattern. Okay, so there is always, keep this at the mind, that the teeth can come with enamel defects. And these enamel defects, because of the white patches, if you take it under microscope, it's a hyperplastic enamel, a rough surface comparing to the fully mineralized enamel. So obviously, when it's a rough surface, it's going to retain more plaque, more food debris. And if in the absence of oral hygiene practices, obviously it'll break down in no time. The breakdown can happen in 2 to 3 weeks. So that's the window you have. So you can imagine how early you have to see them. And look at the surfaces. Every single patient, you will see this. It happens in the posterior teeth as well. Okay, so the certain parts get affected because probably the enamel has not mineralized well. It comes into the mouth, and the back teeth, it's a grinder, it's a molar. That's the teeth which the child eventually uses. So that's why you should understand the caries happens in a very bizarre way in the primary teeth. It doesn't happen like adult teeth. You don't see this kind of caries in permanent teeth. Because all the permanent teeth largely forms post pregnancy, in your first 8 years of life. So this is a very unique pattern and very unique situation, and it needs a very unique understanding of this disease. Now, there are another variation, or I can say there is another terminology called early childhood caries and late childhood caries. If a child survives without any caries up to 3 years of age, you'll have very minimal breakdown like this. 4 years, 5 years, you have typical very small caries, which is only between the two central incisors or maybe 1 or 2 posterior teeth, because the teeth has come reasonably well, probably, or the demineralization has happened because prolonged accumulation of substances in the interdigit in the contact areas. If you see here, the high frenal attachment can direct the fluid exactly towards the midpoint where there is a tight contact, and absence of oral hygiene or practices in infancy can allow food to accumulate there because of the nature of the contact, the way the teeth is being assembled. Very rarely you will see caries in a spaced dentition, and if there is no enamel defect, you can be rest assured the child will not get caries in the proximal side. If it's an open primary dentition where there is no contacts and a fully spaced primary dentition with a lot of developmental spacing. So this is there is a new classification. Probably it's a very interesting small 1.5-page paper. They define this as early onset, early childhood caries and late childhood caries, which happens after 3 years of age, right? So I can send all of these papers to Dr. Manikvasam or anybody. You can email me. So I want you to keep this as a clinician, because as I told earlier, you treat more children than me. And I believe that this should be more and more known to general dentists and anybody who's handling children, in fact, more amount of pediatricians as well. So now if you look at the data available in primary dentition, there is very, very minimal data available on 1 year of age. There are no studies. Nobody has studied at 1 year of age in infants. There is a study which we have started now, which is going on. We will probably have the data next year, maybe a little later than that. In infancy, in 1 year of age, what is the prevalence of enamel defects or hypomineralized enamel, or whatever the term you can use it. And all these are systematic reviews. Each of the systematic review has included studies on primary dentition. If you look at the number of studies reported in 1 to 2 years, there's only few studies, and most of the studies have reported 2 years and above. Okay, so very, very limited data available because what happens is the enamel defects stay like that for only a couple of weeks or a couple of months, then it becomes a cavitated lesion. Then probably people don't diagnose this as enamel defects or enamel hyperplasia. They might mark it as caries because it's obviously enamel breakdown is there. So having said that, now what is the relevance to the practitioners? So I know it's more for your practitioners, but so you can focus on the clinicians box, because there will be a few slides like this. But as I telling, this is not new information, but we put the first paper together in 2018-19 that has changed. I go to so many conferences, national, international conferences. That paper has been cited time and again. And that paper is cited for, as a clinician, that changed my practice in terms of managing this disease, because I realized that point of time that the teeth are not coming normally. What the parents are telling is right. The teeth comes with a defect. Only thing, it breaks down in such a short span of time. So you have an opportunity to work with 1-year-old children. Please examine them. And if you see these defects, vigorous infant oral care measures, just wet cotton or gauze wipe after every meal or every feed can really help and prevent enamel breakdown. And you might want to apply frequent fluoride varnish application. You don't need a pediatric dentist to do that. A general dentist can apply 3 or 4 applications in a 3 to 4 months time if you see these defects, and it can completely remineralize the vulnerable enamel. So I skipped these researchers and policymakers part. Let's go to the Association of Sleep Time Feeding Practices and Early Childhood Caries. So this was another PhD work, and we developed this scale. We wanted to know, many times they say it's the bottle milk, it's the breastfeeding, and there is always a fight between the pediatrician, dentist, and pediatric dentist. They say you breastfeed till 2 years, and we say, no, you sleep time feed, teeth will break down. So we wanted to solve this, and we did solve this by a series of papers. We did a very good case control study. We first developed the scale, and after developing the fee scale, we interviewed around close to 600 mothers we recruited, and 600 plus, maybe 300 of them with early childhood caries, 300 of them without early childhood caries, went back to this role of feeding practices. And we found that sleep time feeding, when I say sleep time feeding practice, it means at the beginning of sleep or after the child starts sleeping, in between sleep, okay, or early morning sleep. The child might, don't take milk in the beginning of sleep, not in the middle of the sleep. The child takes milk at 4 o'clock in the morning and sleeps for 2 hours. So that's an early morning sleep. So we categorize the sleep time as 3 different questions. At the beginning of sleep as 1 question, in between sleep, anytime up to early morning, and early morning. So if you have any of these feeding practices, you will never see a child with a full-blown early childhood caries who never had sleep time feeding practices. I've not seen one yet. So it has a very strong relationship. Okay. When you ask the parent, does your child take milk in the night? Many times parent might say, night means they might think it's 8 o'clock. They might say no, but the child might take milk early morning at 4 o'clock and sleep till 7 o'clock with a bottle in the mouth, or there could be on-demand breastfeeding as well. So there is a very strong relationship. Now, what do you want to do with this? What we understood is, if you examine a child, the child has no enamel defects, the enamel is well mineralized and nice, shining and glowing enamel, you might want to let them go with whatever feeding practices they have. But if they have these enamel defects, and if they have sleep time feeding practices, there is a high risk for developing cavities. So it's not the milk which is causing the problem. We should clearly understand that. So we don't stop the mother to breastfeed. We ask them to see whether you can feed in the daytime. Okay? When the child is awake. You don't let the child sleep with this, because if they have enamel defects. So now we know that if they don't have enamel defects, they're pretty much, that's why you see a lot of children who had sleep time feeding practices don't have any cavities. So that's why the controversy itself. But in the absence of enamel defects, it's very unlikely that they develop this early childhood caries. So we understand that now very clearly. So we also understand that the milk is not the problem. The underlying enamel surface is weak, poorly mineralized. On top of that, this milk accumulates through the night. And most of the time, bottled milk is all the powders which has sugar in it. Obviously, it's a rough surface, it sticks more. Obviously, more demineralization can happen and it can break down faster. So this is the mechanism by which this process happens. So I'm again look at this, because sometimes when you say that you have to stop the breastfeeding, we have done this advice almost 10 years back. But once we know this process, we don't do that now, because that's a big problem. That's a big controversy between your pediatrician and the dentist. So you might want to first examine them thoroughly. Is the enamel intact? And if it's fine, then probably you might want to watch them and once in a while and give advice based on the need. So be careful with what you say in this aspect. So we developed this protocol called Sustained Anticipatory Guidance. It's called SAG. And now we are working on the mobile application. Based on this, the NIH has funded around close to 7 to 8 crores. And we are in the project. We are 2 years down, another 3 more years. We should have some mechanism to handle this in a big way. So we also developed this MAC charts to educate the parents. And we have used this in our practice. We have printed them and we asked them, does the teeth came like this? I'll show you those charts and the concept of SAG. The SAG is the first cohort we started in 2017. We took 43 children with cleft lip and palate because they are already in the healthcare system. So before the teeth came in, we brought them into our study. We saw them till 2.5, 3 years of age. And we could bring them, almost majority of them, cavity-free, up to the age of 2.5, 3, with sustained guidance through WhatsApp phone calls, providing the oral hygiene aids, gauze pieces every 3 months, and keeping in touch with the parents. And that's why we named this as sustained guidance. Anticipated guidance is an established philosophy. But how do you guide this, keep this guidance with the parents in a sustained manner? So we brought this terminology called SAG. And then we Smile Train funded another 90 lakhs to bring the second cohort, 83 children. Now that's a policy followed across the globe in the Smile Train projects all over the world. There are so many pilots running in many countries, and all happened from the center, and from the research and outputs came from here. So these are very interesting. You can enroll patients in your practice, provide them guidance like this. This is not very high-tech pediatric dentistry. It's simple dentistry and understanding the science and keeping the children in your practice and provide them guidance as they go along. So you might want to read these papers. And we provided all these aids in a kit, a finger brush, and a toothbrush and some toothpaste and gauze pieces. Then we kept sending messages and some telephone calls, etc. And we also sent the chart. When the first tooth came in, we asked them, is any of your child teeth which is coming inside the mouth, does any of your teeth has these changes? If any of these changes are there, send a picture in a WhatsApp, and we look at that. Okay, then come for a fluoride varnish. So you can identify early. We have technology now. We have so much, we can all online consultations and remote health monitoring. All these things are effortlessly feasible. And so we could do this in a fantastic way over the years. And this SAG basically has completely changed again the practice in our clinic as well. And the MAC charts is the key. That's one of the probably the early diagnosis tool available to detect this as soon as the tooth comes into the mouth. As of now, across the globe, a simple chart. Probably, I think I have, these are the pictures of the chart. And if you look at the chart, the first two rows, or that's how the tooth comes into the mouth. And if you don't, act quickly, if you ask the parents, you take this chart and ask the parents who come with the nursing bottle or whatever name you call it now, nursing caries or baby bottle syndrome, whatever. You ask them, does your child's teeth came like this when it came? Most often you see at 2 years, 3 years of age. And when you ask them, almost everybody will say, yes, doctor, the tooth was like this when it came into the mouth. And in a very short time, it breaks down. And that goes to the moderate stage. And you leave it untreated, it goes to the severe form. It becomes root stems by 2.5, 3. Sometimes now it's even at 2. We see children with 4 root stems. Because that means the entire tooth had a white patch, the entire labial surface. So that's why it's gone completely in a very short span of time. And wherever these patches are intermittent, or it is a small line, a thin line, like the image on the first row, they break down only that part. So the breakdown is little less. Then by the time the child comes to 2 years, the feeding practice stops, and the challenge is the oral ecosystem changes. So it might get arrested at that stage and remain there. So I can send you these papers as you can go through them at your time, at your convenience. Now, if you look at the clinician's perspective, you can have your guidance for the infants. Now, many of the patients will come with a child to your practice. It is mandatory. If they come with a baby, they get a free examination in my practice. Because I'm telling you, every infant I examine, in fact, the infant doesn't come for the treatment. They brought the infant because that's a newborn child, 1-year-old, 6 months, and they have a younger child, 3, 4 years. They come for that child's consultation, and we make a mandatory examination. You won't believe, every second or third or fourth child, we might pick up the child with an enamel defect. The teeth coming in, you have a white line. We tell them, hey, this is how it starts. And be careful. And you start with your infant oral care measures. What is infant oral care measures? Simple things, wet cotton or gauze, wiping after every meal, every feed. It is not, apart from morning and night brushing, you can use a finger brush or a baby brush, but take a bowl of water when you feed the child, when you give whatever food in a bowl, take another bowl of water, put a piece of cotton or a gauze piece or a clean cotton cloth. And soon after you feed, squeeze the cotton, wipe off the anterior teeth. That's all you need to do when upper 4 and lower 4 incisors are there. It's very easy to get this consultation going. Now you also have another child enrolled in your practice as a patient. Your first consultation was free. And as you go along, you will be surprised that you might be preventing more ECG than any pediatric dentist is ever doing. So don't leave them if they're into your practice, because you'll be surprised tomorrow when you examine the next infant and put them in knee-to-knee position, take a wet cotton and, wipe off and see. You will be surprised. The infant will cry. Of course, you have to learn how to examine an infant and all these knee-to-knee position. Very simple, basic thing. You don't need a course. You just have to read a couple of chapters, and in the books, you will get this in your practice. So coming to the another important part called OXU studies. So the OXU studies started with my daughter. So this is her teeth. And she was 3 years old when I first saw this, 2.5, 3 years, because I also read as a pediatric dentist, one of the papers or one of the, I don't remember exactly where I read, 98% of pediatric dentist children in the United States are cavity free. 98% of pediatric dentist children are cavity free. That means it is preventable fully. So that means it has to be preventable in the practice as well as in the society as well. So when she had this kind of a contact, I was very surprised that because until that point, I never paid that much attention to this contact, this interproximal contact, and one tooth invaginating into the next tooth. It is very surprising to see how this complex contact is and how easy food can accumulate and you can develop proximal caries. Look at the contacts and the way one first primary molar is meeting the second primary molar. So this is all. You can see the sealant there. And luckily now she's 14 years and could bring her cavity free so far. And including the complex contacts, which you see on the screen now. And that's very surprising. So if you ask questions and if you pay a little more close attention when you examine the patient and pay a little more attention to the tooth surface, the pitch and fissures, the contacts, we might understand this disease better than what was taught to us earlier. So these are the tooth, the exfoliated teeth from her. You can see the contact, the proximal side, and you can see the sealant there and desperate efforts to keep them. But what the textbook has said, the primary teeth contacts are broad and flat, permanent teeth contacts are point contacts. Even now, the book says this, but that's not so. So that's one of the blatant lack of knowledge or information in dentistry as far as proximal caries is concerned. So after we found this, another PhD happened with Dr. Kritika. So we recruited and we brought this classification called Oakes classification. There are variations in interproximal contacts, and there are 4 variations, the four type of contacts. The O is called open contact. The X is called X type of contact. I is called little more broad or little more straight contact. And S is called a curved contact. So this was a big, game changer in dentistry, in pediatric dentistry, in proximal caries etiology. As we go by, we will see the significance of this work and the way caries risk assessment is going to change in the next 5, 10, 15 years. You'll be amazed and you will see how much this is happening in front of our eyes. But we have not found this as one of the important risk factors. So we recruited 1,100 children at 3 years of age, absolutely cavity free in Pondicherry at the age of 3 years, and all of them cavity free. ICDA is 0, that's no non-cavitated lesion. And we categorize these contacts as OAXIS. You can see in the picture, you have all the 4 types of contacts there. And we took a sectional impression and we took these models and we saw them till 6 years of age. Okay, it's called prospective cohort study. So from 3 years to 4, 4 to 5, 5 to 6, 1 annual examination. We took impressions, we took pictures, we followed them up. It's one of the first Wellcome Trust funded study in the country. We got funding for 1 crore and 2 lakhs for doing the study. And this is happening all over the world now. And you'll be very surprised that how this contact can play a major role in proximal caries in children. So this classification came with the initial CBCT study and then multiple, there are 10, 15 papers from this cohort. And I'm going to show you some very important findings alone, which are clinically relevant for a practitioner. And again, I can send you these papers. Now, if you look at the image here, you can look at the contact. If the child has a yes contact, that is a curved contact, one of the tooth is invaginating into the other molar. I'm talking about primary molars, both maxillary and mandibular. If they have a yes contact, the risk for caries is 124 times. The odds ratio is 124 times in a retrospective cohort. Okay. And if you have eye contact, the risk for caries is 24 times higher than open contact. So imagine if you capture this at the age of 3 years, and if the child is not brushing the teeth properly, and if they're assuming that the child has no caries, you're seeing a child at 3.5 years, and if you examine this molar contact, if there is an eye type of contact, that has a risk of 24 times to get proximal caries sooner or later. Okay? And if they have a yes contact, it has 124 times. And this is the retrospective cohort data. We also had a proximal cohort data, okay? Sorry, prospective cohort study. Sorry to go back and come back in the sign. So this is a retrospective cohort. This data is from a Korean population, from a pediatric practice. We took these children, whatever the images you saw before, they have fantastic records of the pediatric patient. So all these things are from the records of the same patient from the past to the future. So it's okay if you don't understand, but that's called a retrospective cohort. Maybe we can discuss later. But this is a prospective cohort. Okay, this is from the Pondicherry population. You look at the model, you look at the A, B, C, D. You look at the open contact. There is no contact between molar. Nothing happens. Saliva goes in, bristle goes in, toothpaste goes in, food goes in and comes out. Easily cleanable. The risk for caries is almost zero. Okay, almost zero. But if you have a X contact, the risk is very, very minimal. Little less than odds was probably 1 point something. But if you have eye contact, it is 12 times. This is a prospective cohort. So you might want to use this in your practice. And if it's a yes contact, 22 times. So you have to watch out, when you examine, pay attention to this. We mark this in our software now. You have eye contact, yes contact in the practice. We tell them if you don't brush properly, you'll come back for a crown 2 years down the line. And it happened many times. So night brushing is the key. The child, if they have a complicated interproximal contacts, they cannot afford to go without brushing in the night. When the child goes to sleep, because that's the time where you can have prolonged demineralization. So you might want to keep reinforcing, repeatedly reinforcing, brush in the night, brush in the night. Night is more important than the morning because the mouth should be clean when the child goes to sleep. And mainly these eye contacts or yes contact. Imagine the bristle doesn't go between the contacts. It cleans only the palatal side and the buccal side. So the interdental area, which is a broad contact, and it is also complex. If you imagine 3-dimensionally, that's like a cave underneath, beneath the cavity, beneath the tooth surface. So when food goes in, doesn't come out. So you need a liquid, probably a mouth rinse can go in there, or maybe a flossing. Even yes contact can be difficult to floss as well. And look at the way these cavities have happened. You look at the eye and yes contacts, completely broken down by year 1 or year 2, it's gone. So it's very important, clinically relevant information. We have series of papers, and we also have a website set up on this. If anybody is doing research on this, they can calibrate themselves. The website is called Oxus Calibration, and this is funded by Ajman University. And we set up this portal, and we allow anybody can log in, create a login. You can go through a training. You can calibrate yourself to identify. It will throw some random 20, 30 images to make sure whether you identify correctly. If you score above 80%, you get a certificate that you've been calibrated for Oxus, and you can perform an Oxus study. It'll be useful for a clinician for you to understand. It has a very nice tutorial. Probably some of these images, what I showed, you will see there itself. So this is the website, and this is the global map in 2023, June. And as and when people calibrate themselves, the map becomes more and more greener because it came from India. So a lot of people got calibrated themselves. And you look at the image, how it's changed in 2024. Look at the interest in Oxus studies. So many countries, they are investigating these Oxus contacts across the globe. This is June 25. The more and more it becomes greener, that means more and more people are logging in, registering, and calibrating themselves for Oxus studies. So this will completely change proximal caries management and international guidelines on proximal caries, risk assessment on proximal caries. will dramatically change in the next 5 to 10 years. I'm talking about international guidelines. So you might want to watch out in your practice as a clinician. So this is the development of the website published as a paper. And what is the relevance to the practitioners? At 3 years, caries free. In our Pondicherry population, they were caries free at 3 years, no anterior teeth cavity. We saw them till 7 years. Only 10% of the children got caries. Overall, in the 1,200, only 10% had caries. That means it's a big lesson. If you bring the child cavity free up to 3 years, from 3 to 7 years, you have only a 10% chance. The 10% caries is always or almost always is with the IRS contacts. So it's easily you can prevent. So it's not a very complex science. And I hope I'm making sense in whatever I could explain at this point of time. So mark this in your routine charting, in your routine examination, dry the surface, see that. If you don't want them, they come back with contacts, proximal caries. We have seen, and it's an integral part of practice. So now what's the problem with the ECC and impact on general health? We did a systematic review on how it's connected to iron deficiency anemia. Okay, it's not cause, ECC does not cause iron deficiency anemia, but if you have a severe early childhood caries, there is a very high possibility the child cannot eat very hard substances, chew very hard substances because so many teeth, dentine is exposed. All of us know dentine has multiple dental tubules and odontoblastic processes, extremely sensitive to thermal changes. And if you brush that teeth, the child is going to cry. We tell them you have a full-blown early childhood caries, don't brush the teeth. It's not going to help in any way. You brush 4 times a day with a full-blown disease like the images what I've shown earlier with the front teeth damaged. You brush 4 times a day, it's of no use because all the dentine exposed will cause so much of sensitivity. For your information, I think you might know this as well. 1 square millimeter of a dentine, 1 square millimeter, not centimeter, 1 square millimeter of dentine has 20,000 dental tubules. So you can imagine how many dental tubules are open in the early childhood case affected enamel. Imagine how the child will allow the parent to brush, how they can bite hard substances. So there is a very high risk the child goes in for a nutritional deficiency, and the odds is 6 times there is a higher chance child getting iron deficiency anemia. So the biggest mistake for dentistry came out of medicine as a separate stream. We should have stayed with them. Like every other medical specialty, the whole world is trying to struggle to integrate both now. But because we always, when they fund, we always feel that we are neglected. Oral health is less important because we came out of the health stream. We said we are dentists, we are well-developed specialty, we are on our own. So health sciences went, and now it's a big struggle to go back and integrate with them. But it has to be some kind of integration should happen if big changes has to happen across the world. So the management strategies, early interventions, this is what I want you to pay attention to. One example I'm going to show, and we'll wrap up in another 5 minutes. And the same images I showed you, and the same picture I'm going to show you. You can see the image on the screen. The same tooth. You can look at the remineralized patches, remineralized enamel. I've seen numerous presentations. I've not seen remineralized enamel shown in the presentation to a naked eye. I'm showing you in front of you. This patient is from a practice. You look at these teeth as the child has grown in. We've done 3-4 application, stopped sleep time feeding practices, initiated infant oral care measures, vigorous infant oral care measures. I'll show you this picture. This is plus 31 months, almost 3 years later. You can see the same tooth, how much it is kind of remineralized. And also there is another new patch coming from the one which you see in the top image. So that's why I say the process of enamel development is interrupted not in a continuous way in pregnancy. There is some disturbance, interruption happen, then normal enamel formation happens. Then there is again interruption, so enamel doesn't form well. So it depends, whether it's continuous or intermittent. Look at this. This is plus 42 months I have to this child. And I think sorry for this picture. This is the same child's permanent incisor, reasonably well. not much of, sorry, the picture quality is not great. So we do a lot of full mouth rehabilitation, and there's no other alternative to treat a young child. You bring them here, we treat them in 3-4 years, 2 hours, 1.5, 2 hours, dramatic change in the life. And we do a lot of strip crowns, zirconia crowns. And if the child is cooperative beyond 3.5, 4 years, they might sit on the chair. We do it on multiple chair side visits, and all these things are possible. But full mouth rehabilitation is, if a child is less than 3.5 with multiple teeth damaged, it's very unlikely that you can provide a full rehabilitation on the dental chair. So look at some of the, I'm not showing the pictures of rehabilitation. Let me conclude. Probably I can answer questions. If you have some questions, I'm open to answer, but I'll conclude with these slides. I keep meeting this person. This is the most experienced researcher in the world on early childhood caries, Professor Norman Tinenoff. And this is pretty much few months back. And every conference we have, this time I showed this enamel hyperplasia presentation, and I asked him, and do you think the tooth comes with a defect, or this happens because of plaque-induced demineralization? Then finally he kind of agreed, yes, there is a possibility that now what you say, that the teeth are coming with the defects, and we haven't seen that way so far so many years. So that's with that thought, because he has written in one of the paper, and which is my, I always cite this sentence. This is the conference in 1998-94 conference where they defined early childhood caries for the first time. And this came as a supplement in Community Dentistry Oral Epidemiology Journal. And the first paper, which is written by Norman Tinenoff, it says that the first report of this early childhood caries happened in 1962. And he says by 2032, he would like to believe that the era of dental caries in infants will be long gone. We have 7 more years to go. I feel with the technology we have, a lot of things can happen now. So let's see, we are doing our part. And let me conclude with my, small statement. And that's I would like to read. We have taken extraordinary efforts to conquer the moon and Mars. We know the surface of them. These surfaces are hundreds and thousands of miles away. We are exploring the possibility of life there. We are exploring them for future livability. We don't need them today, but for the future. Unfortunately, we have millions of children suffering with ECC today. Every third or fourth child less than 3 years across the globe is possibly suffering with ECC. They're struggling to eat today. They're struggling to brush today because we do not know the 1 mm thick enamel completely. Let us understand this enamel defect erupts with the tooth into the oral cavity. They're not plaque-induced demineralization. Almost all of the ECC patients under 3 or 2 years of age are patients of hypoplasia-associated ECC. Moreover, hardly any research has taken place in this area in spite of significant literature available. What I have shared today on enamel hyperplasia and enamel defects and early interventions are small, tiny, little efforts from the Central and Pedo Planet Children Dental Centers in suggesting to investigate further on the existing knowledge. If Mars and Moon are conquerable, I cannot agree that 1 mm enamel surface is unconquerable. If you can understand the enamel surface, then probably there is a possibility that ECC can become history. So thank you for your time and your undivided attention. This is my email ID, and I'll be happy to answer any questions.
Thank you so
Let me
much,
stop
Dr. Muthu.
sharing.
It is really a wonderful session, Dr. Muthu. Really an eye-opening session, I could say. Every dentist needs to watch this. The perspective of seeing a child at 1 year, I have never imagined. Seriously, wonderful points, Dr. Muthu. And I'd like to open the session for doubt clearing for all the audiences. So if you have any doubt, you can unmute yourself and you can ask the question. Thank you.
Thank you, Dr. Manikosan. Yeah. Any questions?
Anyway, I will start the first question. So what about the fluoride varnishes, doctor? As otherwise, there is no issue. The child is very healthy till the age of 3, 4, 5. So, is there a recommendation to use fluoride varnishes in the chair periodically?
Yes.
Do you recommend that?
Yes. If the child is a 3-year-old cavity free, and it's a good time to have an annual application on the chair side, because it's a simple procedure to introduce. You have a disposable now sachets with a applicator tip or a brush. So you can keep them on, you can introduce the suction slowly, you can introduce everything, and a simple application. Even you can keep the child on the mother's lap, and a good preventive care can start from age 3, and once in a year is an application. If they're cavity free, it can go on till 14 years of age. That will be a very good preventive plan if the child is cavity free at the age of 3 years.
What about the use of tooth mousse on the hypomineralized areas? Is it really working well? Can the enamel absorb the tooth mousse and remineralize? Is it possible?
If you go back to the images what I showed as a non-cavitated lesion, at that point it can be effective. But very often I see with a full-blown broken down enamel with dentine exposed, and many parents carrying the tooth mousse in their hands given by dentists or suggested by dentist. When you have a cavitated lesion, there is no scope of remineralization. You can only arrest with SDF kind of thing, but it's not going to remineralize and come back to original enamel. Only a non-cavitated lesion, which is as a white line or a diffuse opacity or a demarcated opacity, can be remineralized, as I showed in the last case, where you can see the patches of remineralized enamel. That is feasible. But the moment it breaks down into a cavitated lesion, it's very unlikely your tooth mousse is going to be of any help. It's not going to work. But when you have a non-cavitated lesion, only white patches, yes, it can remineralize.
Usually, general dentists like me, used to prescribe the fluoride Muthu, the paste and all that for the child. We don't discuss about the fluoride, the amount of fluoride we have in a toothpaste. Generally, the patient comes with a teeth decay. We just give them fluoride toothpaste. So, what is the view of a pediatrician like you on that?
The current recommendation for a fluoride toothpaste usage is from birth, you use a regular toothpaste. But only thing, the quantity is controlled. Up to age 1 and 2, use a rice grain size of toothpaste. Then beyond 2 to 3 or 4 years of age, by the time they can spit it out, until that point you use a peanut size, and then you go on to a regular size of the which you do. So normally the swallowing reflex becomes voluntary, that is, the child can control and spit it out, happens around 3 years of age. So until that point they will swallow. So you want to keep the quantity very minimum. So rice grain or a smear layer of the toothpaste is recommended. And they say it's 1000 ppm fluoride is fine now. If they don't want, because some parents are reluctant to use, you at least give a 450 to 550 ppm of fluoride, the kids toothpaste, most of the kids toothpaste, but don't give a non-fluoride toothpaste unless they are absolutely cavity free. It's better to have a fluoride toothpaste from the beginning.
And there are some questions in the chat box. Continue, please.
I can see Dr. Narmada. Hi, Narmada. Dr. Raghu. I can see some of the familiar faces. Nice to see you guys.
Hi,
And
hi Muthu. Excellent lecture by you.
Thank you. Thank you very much.
Continuously I am watching. Very useful, very deeply analyzing lecture. You are extraordinary. You are proving again.
Thank you.
Congratulations. Very, very useful lecture. Thank you.
Thank you very much, Dr.
Okay.
Narmada. I'll see the question here. There's one by Sharon. Does MI varnish help? Yes. If you have a non-cavitated lesion, varnish, you can use a bifluoride, you can use a MI varnish, you can use a tooth mousse. I use a bifluoride the varnish, and you can use fluor protector. It's available from Ivoclar. Any of these varnish can really penetrate into the enamel and it can remineralize, but you might need a little closer application. You might want to do it once in a month or two. Maybe we do that 3 or 4 applications in infants in a span of 3 to 4 months time. A quick application, dry it, and just apply only on these front teeth 4 surfaces. So you'll be surprised that it can remineralize, but parallelly you have to do 2 things. One, ask them to do practice
religious infant oral care measures. That is, take a bowl of water, put a cotton piece inside. It's a new habit the mother has to develop. And it's very simple. If you really reinforce this, and if you show the pictures of full-blown early childhood caries, they will understand if you don't do this, it will break down like this. You'll have consequences. So you might want to really teach them how to apply, how to wipe off. So your varnish, their infant oral care measures should go hand in hand. If they have a sleep time feeding practice, they do, child drinks milk in the night time, say 3 times in the night, cut down to 2 times, bring it to 1 time in over a month or 1.5, 2 months time. Then you ask them to feed as much as they want when the child is awake, but try to get them out of sleep time feeding. So you can continue to breastfeed up to 2 years. But if you don't stop the sleep time feeding practices, if they don't initiate infant oral care measures at home, only your fluoride varnish application may not help. You might want to do all 3 together. So that needs, reinforcement from your side. As a dentist, it's not that advice given and gone. That's what we used to do. They go home, they don't do it. You call them after 6 months, they come back. Did you do the wet cotton gauze? They said no. So you might want to sustain that. You might want to call up and ask, how are you doing? Do you have challenges in that? And definitely they'll be happy about it because you're following up with them and you're providing some support. They might say the child is crying. That's okay. The child will cry. Infant will cry when you wipe, initially. That's part of the game. So in spite of the cry, you can do it in 10 seconds. And after 3-4 days, the child will know that anyway, their mother will wipe the mouth with a wet cotton. So it's not a big deal. It's a very simple practice to be taught and inculcated and monitored. Effortless, the gains can be phenomenal. You avoid a GA, you avoid a general anesthesia procedure. So the gains are so much to do. And sometimes if you don't show the consequences, they don't get it. You should show. That's why the MAC chart will be very helpful. If you don't do this, you're going to come here and I'm going to take you to the theater and rehabilitate and give you a big bill. So that's, the way it's important to educate. And I'm sure you all get infants now. You have more patients coming into your clinic. Yeah, Dr. Venkatesh.
And another question is, how frequently can it be used, sir?
The varnish?
Yes, please.
Okay, the varnish. See, if as you said, if the caries is free at 3 years of age, you can do it once in a year. Pretty much good enough. Reinforced night brushing, you can sustain that. But if you see these white patches at 1 year, 1.5 year, 12 months, 18 months, I would apply 3 to 4 applications in a span of 4 months. Okay, 3-4 quick application. Because that also gives me an opportunity to watch them. Are they cleaning parallelly? You call them after 1 month and ask them, are you wiping the teeth? If they say no, then I will say I may not apply the second application because it might be a waste of time for you. I will keep applying. You don't do anything at home and, you don't stop the sleep time feeding. You don't reduce the frequency. It's going to break down. Then the treatment doesn't work. So there's a combination has worked dramatically well. And if I have to tell whether the infant oral care measures practiced by the parents worked or my fluoride application worked or the stopping the sleep time feeding practices worked, I do not know. We have to do a randomized control trial, another research. It will take another 5-10 years to find out which one is working. But the combination is working and it's not difficult to do that in any setup. So the application is 3-4 times quickly in a 3-4 months time. After that, you can do it once in 6 months. Because you will see the tooth coming out of the cervical area, around the gingival margin, if the white patch is there, if the tooth erupts a little more, you'll see a normal enamel there. Then that means that risky part has come a little more supragingival. Then the chances for breakdown is less. So you might want to keep watching. It helps you to interact with the mother and provide some more support and etc.
And Dr. Kirti Ramajan says, informative lecture, thanks. And Dr. Raghu Ganesh says, so much progress in the ECC should reach more and more people. Hats off to your efforts on this research area and the time to educate us on all this, sir. Very, very valuable presentation, sir. And I don't know, iPhone, the Dr. name is not there. Very professional presentation, sir. Hats off. Role of fluoride, gels, sir, and frequency.
Yeah. Answering that, the gels, earlier we used to gels because we didn't have varnishes at the time, but now you have so many varnish applied because there is enough evidence available that varnishes are more effective than gels. So we stopped using gels. Earlier we used to use the disposable tray and the gel. And but it goes, it's very tricky in a 1.5 or 2-year-old. You can't keep it there, and a lot of restraints and other things. But now when you have varnish available, it's easy to dry the surface and isolate and apply. More effective, more penetration, just 30 minutes. Not to eat or drink anything after the application. So it's always better than varnish is better than gels. In case if you don't have access, I'm sure in India and anywhere you can access varnishes, but otherwise probably gel is better than nothing. Sir,
And very,
yeah.
yes, you can continue.
I
Sir?
see 5 in 10 kids with black stains,
Yes.
even in children under 2 and 1.5, 5 years of age. Sorry, sir. I know this is not the topic today, but I really know is from you. What is the line of treatment? See that black stains, if it is a chromogenic most often that will be a chromogenic bacterial stains, and that doesn't go away with your brushing. But it generally has a 4 to 6 years of period. You might want to do a cleaning. I'm seeing now infants at 1.5, 2 years with the chromogenic stains. And that's a bacterial stain, but probably what I've seen as a clinician from the time it occurs, it has a 6-year time span. You might have to, and if they have good oral hygiene practices, the recurrence is less. If they don't have good oral hygiene practices, they come back every 6 months, 1 year for a cleaning. And it's a little difficult to do a scaling on a 2-year-old or 3-year-old. So we defer until they go to school. And when they go to school, it's more visible on the anterior teeth. We do the cleaning. We do a scaling basically, and we don't scrape down from the pits and fissures, but we take it out from all the smooth surfaces. We don't want to damage the enamel. So that's the way we handle the chromogenic stains. I assume that's what you're looking for. And let me see. Okay, niche topic. Okay, thank you. Stannous fluoride application. I don't see a stannous fluoride product available in the market, at least easily accessible. So you have these sodium fluorides in various forms, and now as they said, other varnishes, other MI varnish, and anything which is a varnish will be more helpful than a little more lighter application like gel or anything. That's helpful. And what is your line of treatment? INS type of contacts. Put the child on a kid's mouth rinse. Night brushing, and at least twice a week. Kidodent, there is only mouth rinse available in Indian market. So ask them to use in the night after brushing, because that liquid can penetrate the INS contact. And maybe twice a week, and watch them, get them for follow-up, see them at 6 months. If you have some more doubt, take a bite wing and probably go from there. And if they have good night brushing, you can protect the eye and yes. But if they are very much into sugar, a simple question: if they like a lot of sugar, that means they are at a higher risk. They might come back at 6, 7, whatever you do. If they eat a lot of sugars, and they might come back at 6 or 7 years with 2 proximal caries, class 2 in D and E. You might have to put a stainless steel crown. But with vigorous night brushing, parallel means vigorous in the sense everyday night brushing. Don't leave a lot of holidays for night brushing. And once a week, twice a week, or thrice a week of night brushing and kidodent mouth rinse can really prevent eye and ears contact from getting caries. And how to apply varnish in under 3 years of age? Yes, under 3 years, you put them in knee to knee. There is a bed kind of a thing attachment available in Amazon. You can sit with the knee and closer to the knee touching, you can even, because sometimes the mothers are a little reluctant to touch your knees and sit, knee to knee position in India. So you have a small bed, infant bed kind of thing. You can put it on top of you and the top of the parent, put the infant on your lap, and, stabilize the head with one hand, and take a piece of cotton, have your assistant holding a disposable cup and a cotton, just wipe off the enamel and take the fluoride varnish and apply on the front surface and back surface. And if you feel that you have to apply at the back as well a lot, just use the suction once or twice, sit closer to the chair, bring the suction and take it out, the excess, whatever is there in the saliva. And that's a pretty good application. And about 3.5, only one coating, just dry it and apply it. But don't keep a cotton roll as isolation, because varnish will stick to the cotton roll. You might want to isolate, hold that side and dry it and immediately apply. That's why you might need 1 or 2 more hands. It's better you have an assistant holding on things, because your one hand is occupied with stabilizing the head of the infant, Just you can do it in less than a minute. And about 3.5, yes, you can put them on the dental chair and do it. My take-home points, even before the teeth comes in, yes, enamel is defective, educate them, show them the match chart, and do SAG. You know, that will keep the family and the children in your practice. Do SAG, apply varnishes, keep checking the interproximal contacts, even at 3, 4. See, what happens is when you look at a gross look, I always say this, you know, when you look at the mouth next time, just pause for a moment and look at each tooth for a few seconds with absolute attention and see why that surface is carious and why not other surfaces. Okay, you will learn so much about the mouth, you will learn so much about the patient, probably their practices, and you might be able to give more lasting solutions to them. Right? Okay, thank you. Covered everything. Okay.
One more question I would like to ask.
Yes.
Do you recommend the SDF application, which makes the teeth look black and ugly for the patients? Or is it an intermediate procedure before going for the crowns? How do you see that?
See, there are patients who are extremely frightened about general anesthesia. So they will tell you do anything, doctor, but not general anesthesia. Categorical. And the child has a full-blown disease. Now the only alternative you have is apply SDF, and it's going to become black, jet black. And there are children who have come later at 3 and 2 years. We applied SDF. 3.5, we have admitted them under general anesthesia and did a crowned everything. Some of the children cooperated on the dental chair. We put a crown on the chair side, but SDF is very effective in arresting the caries. At least the disease doesn't progress. You know, otherwise you'll go for pulpal involvement, you get an abscess there. You know, all these complications will happen. The child will not be able to eat at it. But once you arrest the caries, at least it's not spreading to the other teeth, and the extent of disease is controlled. The sensitivity decreases. The child can eat little more better, but you have to keep again checking. Not all the surfaces gets 100% arrested. Sometimes, you know, in spite of that, you might want to apply again after 6 months, maybe, you know. So, yeah. Venkateshan's hand is raised. Is there a question there or, sorry, Dr. Venkateshan? I don't see him in the chair. Anybody? Okay. Any other questions? Anybody?
It means a lot for all the general practitioners, sir. Always you have been a source of inspiration and knowledge, sir. Thank you very much.
Thank you.
And I have missed reading many more thank you, sir. And it is there, and everybody is going to thank you anyway. And few more pressure is going to come on me to post in YouTube as early as possible, because usually we keep it on Saturday or Sunday. Even during the weekdays and in the lunch break, people are showing so much interest to learn. So that's great, and especially from you, Dr. Muthu. It's really a wonderful hour we spent with you. Thank you so much again. So if there is any more question, you can post in Dental Vriksha community. I will pass on to Dr. Muthu and also get some journals from him to post in the group to share knowledge. Thank you. Thank you so much, Dr. Muthu.
Thank you, Dr. Manikvasan, for the opportunity. And thank you, everybody, for joining. Appreciate all your time and best wishes. Have a great pediatric practice in your general practice. Thank you very much.
Bye-bye.
Bye.